Hi, you're listening to the Psychopharmacology Institute podcast. I'm your host, Dr. Wegdan Rashad, and this is the show that aims to help you, the mental health clinician, stay sharp on Psychopharm. Today, we will be featuring an interview called Expert Consultations on COVID-19 related delirium with Dr. Scott Beach. You can earn 0.5 CME credits after listening and answering some questions to this interview. Link to the questions are in the transcript. Keep in mind that this is if you become a Premium Plus member, okay? Now, that's out of the way. Let's get nerdy. I think you'll enjoy this one and learn a lot of psych nuggets. Hello, everyone. You are listening to the Psychopharmacology Institute's audio update called Expert Consultations. We interview clinicians on issues that are relevant to our everyday psych practice. I'm your host, Dr. Wegdan Rashad, and today I have with me Dr. Scott Beach, and we will be discussing COVID-19 related delirium. Now, whether or not you are managing these cases, I think you will enjoy the discussion and hopefully learn a nugget or two for your own psych toolbox. Dr. Scott Beach is an assistant professor of psychiatry at Harvard Medical School and program director at the MGH McLean Adult Psychiatry Residency Training Program. Dr. Beach and colleagues recently published a paper in May 2020 entitled Neurocovid Pharmacologic Recommendations for Delirium Associated with COVID-19. It was published in the Journal of Psychosomatics. So without further ado, let's get started. Delirium can occur in any patient with severe psychiatric or medical condition. When I was reading this paper, I found that the rates of delirium in COVID-19 positive cases were relatively high. So my first question is, why is that?
One of the things that we're still unsure about with regards to delirium in COVID-19 is why we're seeing higher rates. And there's a lot of theories for that. One of the theories is just that this is a secondary delirium, very similar to what we would see in patients with critical illness that may be a downstream effect of really serious medical illness. There's also some ideas that because of the huge amounts of systemic inflammation that take place in COVID-19, that is resulting in increased rates of delirium, and that it's actually the cytokine storm phenomenon that's causing a lot of the delirium that we're seeing. But then there is some speculation that some of what we're seeing may actually be a primary effect of the virus invading the CNS. And the fact that we know the virus can get into the olfactory bulb and cause anosmia, and the fact that there have been now a couple of cases of viral encephalitis where they've actually detected virus in the CSF of patients, does raise the very real question about whether some of the delirium we're seeing is actually a primary delirium that's caused by virus in the CNS. And so we may eventually get to a point where we think about primary delirium and secondary delirium as somewhat different in patients with COVID-19, and those may also have different approaches and different management strategies.
Fascinating. So primary and secondary delirium. I wonder how delirium in COVID-19 infected individuals differs from everyday garden variety delirium.
Yeah, so that's a great question. I think one of the most important takeaways from what we've observed over the past couple of months. So there are a few things that seem to make delirium with COVID-19 somewhat unique. One is the rates of delirium that we're seeing and that are being reported are higher than rates of delirium would be even for patients with similar degrees of medical illness. So if you compare patients with COVID-19 who are in the ICU to general ICU patients, the rates of delirium are higher. If you compare mechanically ventilated COVID patients to mechanically ventilated patients without COVID, the rates of delirium are higher. And even for patients with severe illness, as we're seeing in COVID-19, the rates of delirium do seem to be higher. So we think there's something about the virus that predisposes patients to develop more delirium when they're infected. The other thing that we're noticing is the way that the delirium presents can be slightly different. So early on, one of the things that we observed were that patients with delirium in the setting of COVID-19 were often requiring much higher rates of sedation. And then as sedation began to be weaned, they experienced much more significant rates of agitation, and their agitation tended to be more severe than we would typically see with delirious patients. The other thing that we observed was this very unique phenomenon where there was a constellation of symptoms that we wouldn't typically see in delirium that we were seeing with much more frequency in patients with COVID-19. And those symptoms included some increased muscle tone or rigidity, a phenomenon of abulia where patients would sort of lose spontaneity, they would lose spontaneous movement, and then they would also develop a progressive mutism or alogia, so kind of the loss of spontaneous speech. And we saw that in several cases that we were following in the early weeks of COVID-19 at our hospital. Initially, we wondered if that represented a catatonic syndrome. And so we tried to use lorazepam in a few of those patients, really with pretty limited success. And so what we concluded was that it may actually be representative of a phenomenon known as akinetic mutism, which is related to catatonia, but typically associated with a specific brain lesion or general inflammation in the brain. And it seemed like that fit the picture of what we were seeing. So higher rates of akinetic mutism and catatonia-like symptoms in patients with COVID-19 than we would typically see with delirious patients.
So to summarize, this type of delirium is more prevalent, has more severe agitation, requires more sedation, and regarding symptoms, we have more rigidity, abulia, akinetic mutism, and in short, catatonia-like symptoms. What about other symptoms of delirium, Dr. Beach?
Yeah, so we were generally finding that the usual symptoms of delirium were also present. So those include classic things like inattention and cognitive dysfunction, disorientation, a sleep-wake phase reversal, the kind of classic waxing and waning picture of delirium where it tends to be worse at certain parts of the day and better at others. Perceptual disturbances like hallucinations and delusions, all of those features that we would typically associate with delirium were also present in these patients. And then some of the neurological findings that we would often associate with delirium were also present. Things like a multifocal myoclonus or frontal release signs also seemed to be present. So there didn't seem to be anything that was specifically missing from patients who were COVID positive, but instead there were some additional features present that we might not typically see in delirium.
Moving on to the management of these cases, how would we approach treatment?
So, this was an interesting time, I think, for everyone in the field because there really is very limited evidence base in terms of how to manage patients with delirium. And I do just want to make an important distinction between management and treatment, which I think has become more of an important distinction over the past few years. So the treatment for any patient with delirium is really only to reverse the underlying cause. So for patients with COVID-19 who are delirious, the treatment is really to improve their respiratory status, to improve the other sequelae of the virus. And that is really the only thing that will definitively shorten their delirium or cure their delirium, so to speak. And so instead, what we often try to do with medications is we try to manage or mitigate the symptoms of delirium. And we primarily focus on two groups of symptoms. One is agitation, which is often seen in patients with a hyperactive delirium. And agitation has the potential to put both patients and staff at risk for harm. And then the other group of symptoms that we tend to target in delirious patients are perceptual disturbances, things like hallucinations and delusions. And we target those symptoms because there's some pretty good evidence now that delirious patients can develop a post-delirium PTSD, and that can have important sequelae and can actually be long-lasting. And so those are kind of the two clusters of symptoms that we tend to try to manage with medications.
So we have two clusters of symptoms to target: agitation and perceptual disturbances. I found the concept of post-delirium PTSD quite riveting. So you mentioned that our evidence base is very limited. How did you manage to construct a treatment algorithm for COVID-19 related delirium at Mass General?
In terms of the evidence base for our recommendations, it was partly based on kind of consensus anecdotal experience on our own consult service. But then we also tried to use a small literature that had been extrapolated from literature on the SARS epidemic as well as the MERS epidemic. And there were some papers published in response to those epidemics about potential management strategies. So we used that as a jumping off point, and then also used our own anecdotal experience, as well as quite a robust discussion that was taking place amongst the national consultation liaison psychiatry community on a listserv that was run through the Academy of Consultation Liaison Psychiatry.
Great. So before we jump into the main focus of this interview, which is psychopharmacology, could you quickly share some key points related to behavioral strategies to managing delirium, keeping in mind that COVID-19 is an infectious disease?
So there are a lot of really good behavioral strategies that we can implement before we need to get to the stage of using medications. And I would emphasize that there's really a pretty robust literature base for non-pharmacologic interventions in all cases of delirium that can certainly be extrapolated to patients with COVID-19. Those include things like making sure that patients have hearing aids and glasses in place so that they have control over their environment and over stimulus. Making sure that we try to ambulate patients early so they're up and active and moving around. Trying to cluster care during the daytime so that patients are not being interrupted a lot overnight. One of the biggest problems with delirium, and one of the things that causes so much dysfunction in delirium, is the sleep-wake cycle disturbances. And so any interventions that can be used to regulate and kind of normalize sleep-wake cycle are also very important. Usually one thing we would recommend is having people present who know the patient well and who are familiar to the patient as a way to sort of continuously reorient them. That was actually a unique challenge during COVID because many hospitals instituted visitor restrictions or visitor bans. And so patients who would typically be able to have loved ones present at the bedside actually weren't able to have that. And so in that case, we recommended making sure that patients had access to charged phones or tablets, often with nursing staff sort of assisting with those devices as a way to be able to continue to communicate with families and be oriented in that way. And another interesting technique that was used in many hospitals was for patients who needed direct observation. Hospitals were often reluctant to place somebody in the room with the patient, as would typically be done just because of the concerns about exposure. And many hospitals in those cases actually successfully implemented baby monitors that were placed in the patient rooms as a way to alert nursing staff if somebody was becoming restless or agitated so that staff could respond to those incidents.
I am fascinated at how everyday technologies are becoming an important part of the management of conditions like delirium. Let's jump to the pharmacological treatment algorithm. In your paper, the treatment algorithm was divided into 5 steps. Let's start with step 1, and that is, to my surprise, melatonin. Why is this the first step?
Absolutely. Melatonin may not be the first thing that many people think of when they think of managing delirium, but it actually is one of the medications that has a little more evidence in terms of helping with delirium in general delirious patients. And that's thought to be for a number of reasons, certainly primarily because of its sleep regulating effects. But melatonin is also potentially thought to have some neuroprotective effects as well. We know that particularly for older patients whose natural production of melatonin declines as people age, that boosting those levels of melatonin can be quite helpful in terms of restoring sleep-wake cycles. So we usually start with melatonin in many delirious patients because it's a relatively benign intervention. It does not have a lot of side effects. It's easy to implement, and it's a medication that most nursing staff are familiar with. Patients tolerate it, and it seems to be helpful in terms of restoring the sleep-wake cycle. The one caveat that I would note for patients who have SARS-CoV-2 or COVID positive is that melatonin is an immunosuppressant, and so it can decrease the immune response. For some patients with COVID-19, this is actually probably an additional benefit because one of the things that we think is happening in a lot of patients with COVID-19 is they're having a really hyperactive immune response to the virus, and that cytokine storm and related phenomenon may actually be responsible for a lot of the symptoms that we see and also potentially for a lot of the delirium that we see. So for those patients, melatonin suppressing the immune system can actually be an additional benefit. but it's important to recognize that there may be some patients with COVID-19 who are struggling because they're not mounting enough of an immune response. And in those patients, you may want to be a little bit cautious about using melatonin because it has the potential to further suppress the immune response. So you may want to look at other markers of immune response to determine if it seems like patients are mounting too much of an immune response versus not enough of an immune response.
So first step, we recommended melatonin, according to the article here, 1 to 3 milligrams daily at around 6 o'clock in the evening, and to dose it regularly at the same time. Great. Now, if that doesn't work, the algorithm recommends we add on a Alpha2 agonist, which is step 2. Tell us more about what these agents do and some clinical pointers on using Alpha2 agonists for delirium.
Okay. So I think often in algorithms relating to the management of delirium, one of the first things that we would think about would be antipsychotic agents, and we'll get there. But for us, because we were seeing some patients with increased rigidity and some of the symptoms that we talked about earlier that may be related to akinetic mutism, we wanted to be a little bit more cautious about using antipsychotic agents in this population. And that is what really sort of pushed us towards starting with the Alpha2 agonists. It seemed like there was pretty good evidence for the use of dexmedetomidine as a sedative agent in delirium. That's now been well studied. There's some good studies suggesting that when people use dexmedetomidine for sedation, that the rates of delirium are much lower than they are with other sedatives, and that patients generally have pretty good outcomes with regards to delirium. And so we sort of use that as a jumping off point. In our ICUs, a lot of patients were being put on dexmedetomidine, and we were noting that patients who were on dexmedetomidine tended anecdotally to have lower rates of delirium compared with other sedating agents. And so that was sort of the first hint for us that there may be something in terms of the Alpha2 agonists. We also know that clonidine is being more routinely used in delirium, and there's been some good studies on this as well. People are using clonidine patches as a way to transition patients off of an agent like dexmedetomidine, but they're also using oral clonidine to help with delirium as well. And so we really felt that the Alpha2 agonists not only had some evidence in delirium in general, but potentially would be safe agents to use in this population because they wouldn't carry the risks for increased rigidity or worsening akinetic mutism symptoms that other agents might. They also are not noted to cause any respiratory depression, which is especially important for patients with COVID-19. The one potential side effect that we were aware of and sort of monitored for is that any of the alpha agonists can potentially cause some hypotension, and dexmedetomidine in particular can also cause some bradycardia. And so given that we know that COVID-19 can have cardiovascular manifestations, it's important to just monitor for those effects. Also mentioned in the article is guanfacine, though that is not an agent that we have specifically used, but there has been some discussion about using guanfacine as an alternative to clonidine. It has a similar mechanism of action, but may have less potential for hypotension and less potential for rebound tachycardia than clonidine has. At the same time, I think it's important to know that guanfacine is really primarily used in pediatric populations, and there is significantly less evidence for its use specifically in delirium.
So to summarize, we have 3 alpha-2 agonists, namely dexmedetomidine and clonidine, with guanfacine used more in pediatric populations. However, we should keep our eyes peeled for potential hypotension and bradycardia.
So dexmedetomidine in particular has been shown to do a very good job of reducing agitation, and there's some evidence for that with clonidine as well. I think the early literature may have, come out of patients with traumatic brain injury, and so physiatrists were using clonidine early for patients with traumatic brain injury as a way to kind of dampen impulsivity, and that seems to bear out in delirium as well.
That is super interesting. Clonidine for traumatic brain injury. Wow. Let's keep moving swiftly on to the next step in the algorithm, which happens to finally be antipsychotic agents. And traditionally, from my training, I would have thought that antipsychotics would be used earlier. I wonder what presentation of delirium would benefit from antipsychotics in the context of a COVID-19 positive patient.
So in terms of patients who would benefit, I would really think back to those sort of two groups that we talked about earlier. So patients who are agitated, and again, we are seeing more agitation in COVID positive patients, and particularly patients whose agitation is refractory to the Alpha2 agonists. I would certainly think about antipsychotics in those patients if their agitation is potentially putting themselves or putting staff at risk. And then also patients who have really prominent perceptual disturbances, hallucinations and delusions. Those can be quite distressing for patients, even when their delirium is more hypoactive and they're not as agitated. And antipsychotics would really be the go-to agents for those. I am also somebody who typically thinks of haloperidol as the first-line antipsychotic agent to manage delirium. Intravenous haloperidol is typically the agent I reach for first. Interestingly, haloperidol is actually on the list of 60 agents or so that are being actively studied in COVID-19. And there is some evidence that potentially because of its effect on sigma receptors, that haloperidol may have some benefit for COVID-19 patients even beyond delirium. The reason we thought about it a little bit less in these patients and had it a little bit lower on the list in terms of antipsychotic agents just again gets back to the concerns about rigidity and akinetic mutism. Because haloperidol is a high potency agent, it may carry an increased risk of that. I do want to point out that intravenous haloperidol is thought to actually carry lower risk of EPS, rigidity, and inducing catatonia than are other forms of haloperidol, like intramuscular or oral haloperidol. But because of that, we felt like we may just prefer to use some other lower potency agents as first line if we're thinking about an antipsychotic. So the agent that we've actually used the most in our hospital for COVID-19 delirium is chlorpromazine, which is an older neuroleptic, first generation, low potency neuroleptic. So it carries lower risk for extrapyramidal symptoms, carries lower risk for inducing catatonia or akinetic mutism. And we like chlorpromazine because it's one of the few options that can be given intravenously. I think the main thing to be aware of is just the fact that chlorpromazine does have some anticholinergic and some alpha-1 blocking effects. So it's important to be aware of those side effects. And it does have the potential to prolong the QT interval, which can be an even more important concern in patients with COVID because of other agents that they may be on as ways to treat the COVID. And the QTC issues may be actually more important in patients with COVID-19 because of some medications that they may be taking, like hydroxychloroquine and azithromycin, which can have QT prolonging properties, and also because of the effects of COVID-19 on the heart itself, which may predispose people to having QT prolongation.
Good clinical nugget right there about IV haloperidol having lower incidence of EPS and catatonia compared to other forms of administration. And then we have chlorpromazine. And you said that was probably the first antipsychotic you would consider. But what about second generation antipsychotics?
Yeah. So other agents that we might consider for helping to manage COVID delirium with regards to antipsychotics, my next two would probably be olanzapine and quetiapine. They're agents that are commonly used on the consult service. Olanzapine has the advantage of coming in a dissolvable pill form. It can also be administered intramuscularly. It's relatively low potency, and so it's not thought to have significant effects on rigidity. So we have been using some olanzapine certainly to manage patients with a COVID delirium. And then quetiapine as well. Quetiapine, unfortunately, doesn't come in forms other than the oral form, and so patients have to be able to take pills. But it's a relatively benign medication with regard to some of the side effects that we would worry about, though hypotension is a potential risk. There's been some discussion of aripiprazole. Aripiprazole is not an agent that is typically used to manage agitation. There's not a lot of evidence that it can be really helpful with agitation. It has been talked about more in the hypoactive delirium when patients have prominent perceptual disturbances or when the extent of hypoactive delirium is really interfering with care. So the patient who's so hypoactive that they can't participate in PT, those sorts of things. So there was a little bit of discussion on the Academy of Consult Liaison Psychiatry listserv about using aripiprazole, and there is a little bit of evidence for aripiprazole use in hypoactive delirium. It's just an agent that we tend to have less experience with. Risperidone, like Haldol, probably carries more of a risk of rigidity and worsening akinetic mutism, so we've tried to steer clear of that agent. and then ziprasidone, just because it tends to have the most effect on QT prolongation of the second generation antipsychotics, we've also tended to stay clear of in terms of using it for COVID-19 patients.
To summarize, we would consider olanzapine and quetiapine. Aripiprazole, not so much evidence, but perhaps for hypoactive delirium. And then we have risperidone, which carries a higher risk of rigidity and akinetic mutism. Now, I'm wondering, why haven't we heard of benzodiazepines yet? I mean, even in combination with antipsychotics, or is that a silly question in this context?
It's a great question. And, I think for decades, this lore has persisted that benzos are bad in delirium.
Yeah.
And I think certainly there's validity there. And we know that benzos can cause delirium, they can worsen delirium, they can make delirium last longer, but they can also have some advantages. One of the reasons I think we've been even a little more skittish about benzodiazepines in the setting of COVID than usual is because of their potential respiratory suppressant effects. And we want to be really careful about that with patients who have SARS-CoV-2. But to your point, there was a meta-analysis done, I think within the last couple of years, that found that actually the best management strategy for all-cause delirium may be the combination of haloperidol and lorazepam. So there is certainly some evidence for combining benzos with antipsychotics. And in particular, if you're not getting a lot of sedation from the antipsychotic, the benzodiazepine may be a strategy whereby you can get away with a lower dose of antipsychotics so that you're not having as many potential risks, while at the same time creating a little bit more sedation. So benzos are in the paper and we discuss them a little bit, but I think there are some reasons to be cautious. That being said, I wouldn't certainly not rule them out completely as a potential strategy.
That's a great tip. So benzos are not off the table. There is some evidence that points towards their use in delirium, but it does make sense to practice extra caution in COVID-19 patients due to the risk of respiratory depression. Fair enough. Let's progress down this algorithm train. So we've covered the first 3 steps, which are melatonin, Alpha2 agonists, and then antipsychotics. Step 4 is trazodone or valproate. Personally, I have a little bit of a bias against valproate due to an experience with a patient of mine who developed valproate-induced hyperammonemia and had altered mental status.
I think your point about hyperammonemia is a good one. It certainly is an idiosyncratic risk factor or potential side effect with valproate. And so if possible, we always recommend trying to check a baseline ammonia before starting valproate just to make sure that it doesn't increase. And of course, valproate can also have other effects on the liver and the pancreas, which we have to be mindful of. That being said, there is some evidence, certainly for the use of valproate in mitigating impulsivity from a variety of factors, and it's really sort of been extrapolated from that literature to be used more commonly in delirium. It's often used in patients with an underlying dementing process who then may develop a delirium superimposed on that. And the valproate can be a very helpful strategy in terms of mitigating some of the agitation and impulsivity that's seen in that setting. One of the advantages of valproate is that it can be loaded, so you can get patients to a good dose relatively rapidly. And of course, the fact that it's available in the IV form is also a real benefit in terms of managing critically ill patients who may be delirious. There is some evidence. There's been a couple of studies where valproate was shown to reduce agitation as well as reduce neuroleptic use in patients with delirium. We are also mindful of the fact that the SARS and MERS literature, in addition to some of the early COVID-19 literature, has reported a variety of neurological findings, including an increased risk of stroke and seizures. And in those settings, valproate may be particularly useful as well.
So valproate can be helpful in managing agitation and impulsive components of delirium, as well as possible seizures. Moving on to the final step, step 5, and we arrive at dopamine agonists. And I'm interested in dopamine agonists, particularly amantadine, because when I thought about it, amantadine is FDA approved as an antiviral for influenza A. I'd like to know about its effects on delirium, but also, is there evidence to suggest that it might actually play a role in having an antiviral effect in COVID-19 positive patients?
It's a wonderful question, and unfortunately, I don't think we know that yet. I believe it's one of the medications that's potentially being studied, but I don't think there's any evidence yet to suggest that it has specific effect on the coronaviruses. Certainly, as you mentioned, it has benefit for other families of viruses. Amantadine is an interesting agent. We don't use it a lot in delirium, but we do use it specifically for patients who have an overlap of catatonia and delirium, which is actually, as it turns out, a not uncommon overlap, but one that's incredibly hard to treat because the standard treatment for catatonia is benzodiazepines. And as we said, we try to sometimes avoid them in delirium. And the standard management strategy for delirium is antipsychotics, which can, of course, make catatonia worse. And so amantadine is something that is sometimes used for that combination. There's not a robust literature on it. There's certainly some case series and case reports on it and a couple of reviews that talk about it. But that's really where we got the idea for using amantadine in this setting, because we were observing patients who looked like they might have akinetic mutism or they might have symptoms consistent with catatonia, but were also delirious. We sort of decided that amantadine may be a good strategy. We also thought about using methylphenidate or amphetamine-like agents, and that has been anecdotally reported as well. The concern there is that there's some pretty good evidence in case series and case reports from the catatonia literature that when you use methylphenidate or amphetamines in patients with catatonia, that you unmask or worsen the underlying psychosis that is present. And so for that reason, we tended to use amantadine more. Amantadine does have the potential to lower the seizure threshold and is contraindicated in end-stage renal disease. So those are important caveats to its use. But the fact that it works pretty quickly and is otherwise well tolerated is certainly an advantage.
Dr. Beach mentioned that amantadine is one of the agents used to manage catatonia. If you're interested in learning more about the treatment of catatonia, we have a full video lecture entitled The Psychopharmacology of Catatonia by Dr. Scott Beach. The link is in the transcript. So officially, we have completed the 5 steps of the algorithm for COVID-19 related delirium, according to the paper that Dr. Scott Beach and co. published in Psychosomatics in May 2020. The full paper is in the reference section, so please check it out. The final parts of this episode address other miscellaneous but relevant agents that could be considered in delirium treatment. The first being vitamins and micronutrients like vitamin C, D, and omega-3. Ooh, that rhymes. Tell us more, Dr. Beach.
So I have to admit, this one is a little bit out of my expertise. I'll give a shout out to Anna Ivkovic, who's kind of our resident expert on vitamins and micronutrients and one of our other CL psychiatrists. But I think what I've learned from Anna is the most important thing that we can do in general for patients is, rather than sort of throwing vitamins at them, is actually to look for vitamin deficiencies. And we found that once we start looking for vitamin deficiencies, we actually find them quite commonly, particularly vitamin C and vitamin D deficiencies. And once you've identified them, I think it's very important to then correct them. And there are guidelines for sort of how to do that and dosing and all that. The only vitamin really that I would think about sort of adding on in the absence of an obvious deficiency would probably be omega-3 fatty acids, which again are relatively benign, are used for a variety of neuropsychiatric phenomenon, and do have just a tiny bit of potential evidence for patients who have cognitive dysfunction in the setting of medical illnesses.
Right. So we check for vitamin deficiencies and replenish as needed, and consider omega-3 fatty acids as well. Has there been evidence for the utility of ECT in the management of COVID-19 delirium, I wonder?
So I have not seen anything reporting on that. So to your point, I think one of the big concerns is the aerosolization that occurs with ECT in patients with COVID-19. And then, we do know just from more general delirium literature that ECT sometimes can be helpful for delirium, but other times it has the potential to induce or worsen delirium. So I think many ECT providers are skittish about using ECT in the setting of delirium unless there's some other very specific thing that the ECT is going to treat. If somebody has a delirium that's due to non-convulsive status epilepticus, or if somebody has a delirium that is due to neuroleptic malignant syndrome, In those cases, ECT may be used, but for garden variety delirium, and I think even more so for delirium related to COVID because of the aerosolization concerns, it's probably not something that many services are trying for patients with delirium.
The other agent that was mentioned in the paper was Remdesivir. There was a recommendation here that CL psychiatrists are strongly encouraged to perform an interactions check when selecting pharmacologic agents with this drug. First of all, what is it exactly, and what does it do? And why should we watch out for interactions?
So Remdesivir is one of the medications that is showing most promise in treating COVID-19 or SARS-CoV-2. So it's an antiviral, and it's actually now been granted emergency authorization for use by the FDA. So many hospital protocols are now putting seriously ill patients with COVID-19 on Remdesivir as part of standard treatment. The reason it's important in our thinking is because it has a lot of potential interactions with cytochrome P450 enzymes. And so it's important to recognize that it may interact with some of the medications that we prescribe. The most notable ones are phenobarbital and carbamazepine, so neither of which is on our algorithm. And we've done interaction checks for the common medications that we're using to help manage delirium, and none of them really flagged for potential interactions with Remdesivir. So it's probably a low likelihood, but still something that we would encourage clinicians to do if they're using an agent that is a little more atypical to help manage delirium, or if they're unsure to just run a quick check given the potential for interactions.
Wonderful. So the antiviral Remdesivir, which is used to treat COVID-19, can interact with psychotropics like carbamazepine. All right, so we are nearing the end of this episode. We've covered the treatment algorithm for COVID-19 related delirium and addressed other agents like vitamins, ECT, and antivirals. I shall ask you one last question, Dr. Beach. What are some take-home messages you would like to give to our beautiful listeners right now?
First of all, the most important thing I would say is look for delirium in your patients. We know that delirium in general is very underdiagnosed, and we don't do a great job of identifying it. And we know that it's potentially more common in patients with SARS-CoV-2. And so looking for delirium and identifying it is really the first and probably the most important step. The next thing I would say is look for atypical features of delirium. So based on our experience, we have seen patients with more rigidity. We've seen patients with agitation that's sort of out of proportion to what we typically see in delirium. And then we've seen patients with abulia and alogia, which are really unusual symptoms in delirium. And if you're seeing those constellations of symptoms, you may want to be a little bit more thoughtful about the medications that you're using to manage the delirium. The third thing I would emphasize is that this is meant to be a practical algorithm, but there's not a lot of evidence to base this on. And so this is really our experience, our anecdotal experience. It's what we have seen work well. But I think there's really a need for better studies, for more things being written about the management of COVID-19. And so I would really encourage people, if you're using an agent that hasn't been used before, consider writing that up as a case report or a case series and really disseminating that. I think this is a time when we're seeing this explosion of knowledge around this issue, but we're really just in the infancy. And I think we could all use additional guidance in terms of how to approach patients with COVID-19 delirium.
So, look out for delirium, keep your eyes open for atypical features, and if you're using an agent that seems to work, consider writing up a case report about it. Sharing is caring. Thank you very much, Dr. Beach, for this wonderfully informative discussion. I have summarized the entire interview in a few points for all you psych nerds who want some nuggets to take home with you. Listen up for the key points. COVID-19 delirium has more severe agitation, requires more sedation. It also has more rigidity, akinetic mutism, and catatonia-like symptoms. Melatonin is the first agent to consider. The recommended dose is 1 to 3 milligrams daily, given at around 6 o'clock in the evening. Alpha2 agonists like dexmedetomidine, clonidine, and guanfacine can reduce agitation with delirium, but watch out for hypotension and bradycardia. Antipsychotics are the third-line agents. Haloperidol and risperidone are not preferred due to increased rigidity. Chlorpromazine and second-generation antipsychotics are preferred. The fourth-line agents are trazodone or valproate. Valproate can be loaded in IV and may reduce impulsivity. Dopamine agonists like amantadine can be helpful in cases where there's an overlap of catatonia and delirium. And that's about it for today's podcast. Thanks very much to Dr. Scott Beach for this rich discussion. I have shared the references below if you're interested in checking out the full paper. Also, since you've listened or read this entire episode, you might as well go and earn your well-deserved CME credits. Follow the link in the transcript and become a premium member and continue learning. Also, if you're a premium or premium plus member and you refer a friend to join our platform, you will receive a $50 Amazon gift card. You can also choose to join our free newsletter to receive weekly updates delivered straight to your inbox. If you have a clinical case you'd like to share and hear it being discussed by experts on the podcast, email me your case at podcast@psychopharmacologyinstitute.com. Thank you. The following people participated in this episode: Dr. Flavio Guzman as a general editor, Andy Rode as the audio engineer, Pamela Gonzalez as the project manager, and myself, Dr. Wegdan Rashad, as the host. We'd also like to thank Dr. Scott Beach for being with us. Thank you for joining us in today's podcast. Until the next episode, goodbye.